England. So if you imagine the UK is a bit like a triangle. We're literally in the middle at the bottom. So we're a coastal city, and we are the tertiary centre for the south of England in that kind of particular area, and we serve out to the Channel Islands as well. So yeah, it's an interesting place to work. But just for that, that's the context of where I'm working, and I do a split clinical research role. So I do general paediatrics in my clinical role, and I do research in all sorts of different things. But one of the main things I've been involved in the last few years is the HARMONIE study, and that's what I've been asked to come and talk to you about today. So there we go. We know that RSV infections are one of the most common causes of lower respiratory tract infections in infants, and there is substantial morbidity as a result of these. And in the UK, they estimate that we have around 33,000 hospitalisations annually for children under 5 with RSV, and about 20 to 30 deaths a year. We know that at-risk infants, so infants who have underlying health conditions, might be ex-premature babies, cardiac conditions, things like that, are at a higher risk of RSV. But because it's so prevalent, the majority of RSV-related hospitalisations are in otherwise healthy infants that have been born at term. And prior to this study and subsequent implementation, which I'll talk about in a bit, the preventative treatment that was available for RSV was palivizumab. Don't know if that was commonplace in Canada, but in the UK, that was only offered to a very small proportion of at-risk infants. And because of the short half-life, they had to receive it every month over the RSV season. So required them to come in and have that injection multiple times during the RSV season. So Sanofi approached myself and one of my colleagues to say, we want to conduct a large-scale clinical trial of nirsevimab. So they've done some smaller earlier phase trials that had shown that it was safe and effective, but they basically wanted to know whether it impacted significantly on hospitalizations. And to do that was going to need a large number of infants recruited to see whether there was an effect on hospitalizations. And they wanted to do it really quickly. So they approached us in autumn 2021, and they wanted to deliver the study the following winter, so in the 2022-23 RSV season. So anyone who's been involved in commercial research, it's not always that easy working with companies to get things done swiftly and efficiently. But to be fair to them, they were really receptive to us, and they had got us involved before they had a draft protocol, but they hadn't finalized their protocol, and they were very receptive to what we said. So we worked together with them very closely, and we set up weekly strategy and management meetings so that we could make decisions rapidly within the management team, and that involved people from Sanofi as well as investigators and clinicians like myself. We wanted to make sure that this study was really easy for people to take part in, both from the perspective of the clinical teams, but also from the participants and the families, because if you're going to try and recruit, thousands of babies in one RSV season to answer a particular question, you need to make it as easy as possible. And we wanted really streamlined data capture so that we could collect the data that was needed, but we weren't going to be collecting lots of stuff that really wasn't needed. So the original kind of draft protocol had all sorts of extra stuff in it. And we kind of drummed it down to say, look, what's the question you're asking? And that is what we need to answer, and that's what we need to include. So we had the option then for digital health record interrogation and remote follow-up rather than needing the participants to come back. So through this, we kind of have worked quite differently with the company. And it did lead to the successful and rapid delivery of a very large-scale industry-sponsored trial. And we do think that this is something that can be used to kind of advocate for this model moving forwards, because it did work really effectively in this case. And we felt that as a result, participants and researchers were more likely to get involved in the study because it was set up very much from a clinician's perspective and how we knew we'd be able to deliver it with the research sites. And we hope that this model can be used for other studies. So it's kind of a little bit of a drum that some of us are banging when we talk to, sponsors and national research funders and things like that. So what did we actually do? So this was an open label, multi-center, parallel two-arm study, and it was comparing nirsevimab, which is a monoclonal antibody against RSV, to no preventative RSV interventions. So there wasn't a placebo or anything like that. The infants who were born at over 29 weeks gestational age were randomized to either receive the injection or no injection, and there were 2 doses. So under 5 kilos, they got 50 milligrams, and over 5 kilos got 100. And then the randomization was stratified by country. So this was carried out in the UK, France, and Germany. It was and also stratified by age group at the time of randomization. So those that were under 3 months, 3 to 6 months, or over 6 months of age. And they had one single visit where they were screened, enrolled, randomized, and received their injection, and then had the training on the kind of app that they were then using afterwards to provide their follow-up data. And then we were looking at hospitalization through the RSV season, and adverse events were monitored as well. So the results of the study were published in the New England Journal of Medicine in December 2023, and some of you may have read that publication. And we found that, so we had a total of 247 sites, and the pictures on the screen just show where they were located. So UK, France, and Germany on the right, France in the middle, UK on the left. And the bigger the purple splodge, the more babies that were recruited at that site. And so overall, just over 8,000 infants were randomized in 7 months, and just over half of those were in the UK, and the rest were across Germany and France. We weren't massively involved in France and Germany, aside from obviously the original protocol that was written, but in terms of the kind of delivery of the study, we were very much running things in the UK to try and make it work in the UK. And the teams did kind of have occasional meetings across the countries, but that was kind of done slightly differently. So there were a total of 8,120 infants were screened, and there were 60 screen failures, and then 8,058 were randomized. So the main results found that in the nirsevimab group, there were 11 hospitalizations for RSV, lower respiratory tract infections. In the no intervention group, there were 60. And actually, the study was stopped early because the primary endpoint was met before we thought it would be, because the effect was greater than what was anticipated. And that equates to an 83.2% efficacy of preventing hospitalizations from RSV, with a confidence interval there that's written there. And then they also looked at severe disease, and in the context of this study, severe disease was defined as requiring oxygen or more, which now some of us as paediatricians probably would say babies that are on a bit of low flow oxygen, that's not necessarily severe disease, but we had to have something that we could make an easy cutoff for. And we know that babies get admitted for feeding support when they don't need oxygen and things like that as well. And sometimes it's more because of the social situation, or they've been in a couple of times and people feel like, oh, maybe we should just keep them a night just in case. So severe disease was anything needing oxygen or more. And so it was 75.7% efficacy in preventing severe disease. And there was no difference in adverse events between the groups. So this slide just breaks it down a little bit into some of the different groups that we looked at. And you can see that on the right-hand side, anything to the right of 0, where the whole bar is to the right of that, shows that nirsevimab is preferential, and if it crosses across 0, or if it was on the other side, it'd be no intervention. So we looked at the 3 age groups, and actually the differences weren't significant in the older age groups, but we had very small numbers in those groups. So there were only 4, for example, in the 3 to 6 month age group, there were only 4 hospitalizations in the nirsevimab group and 9 in the no intervention group. So it just wasn't enough numbers to reach significance. We looked at the babies and depending on their weight at randomization, and there was no difference between those groups. They're both effective, and we looked at their gestational age, and again it was effective in all of the different gestational ages, and again in males and females as well. So the other thing that was looked at was all-cause lower respiratory tract infections through the RSV season. and that had an efficacy of 58%, again with the confidence interval that you can see there. So didn't just reduce RSV, lower respiratory tract infections, but reduced all-cause lower respiratory tract infections as well. So the key conclusions from the study were that there was a consistent efficacy of nirsevimab across the subgroups. And all of these babies are at risk of lower respiratory tract infections from RSV, just from the fact that they're babies. That it was 83% effective in preventing RSV hospitalizations overall and 75.7% at preventing severe RSV, and that it reduced all-cause lower respiratory tract infection hospitalizations by 58%. And the safety profile was consistent with data from previous trials and wasn't any different between the two groups. So following on from the results of this study, in the UK, the JCVI, who are the Joint Committee on Vaccination and Immunisation, so the kind of government body that are the people that are advising the government what immunisations should be implemented in the UK, recommended that nirsevimab or maternal vaccine. So you'll probably all be aware that there are some maternal vaccines that have been shown to be effective against RSV, and that either of those would be suitable for a universal programme in the UK to protect infants from RSV. And I think, it's a very diplomatic recommendation from the JCVI. And in the comment, they said they recognise the significant burden of RSV illness and it has a considerable impact on NHS services during the winter months. And officials are developing policy options regarding the expanded RSV immunisation programme to protect infants and older adults. So that was kind of where things were at the UK when the study was published. So Spain was the people that they were the ones that were way ahead of the game. So this region in Spain called Galicia, and if you're interested in this data and you want to look at it more, the web link is at the top of the slide there, and they recommended the implementation of nirsevimab before the RSV season last year, so before the 2023 to 24 season, and then they basically looked at all their data weekly through the season. So on their dashboard, you could go and see what was happening like every week, and it was really interesting. So I've just pulled out a few of the graphs from the final report from their 2023 to 24 season. But basically, so you can see on the left-hand side, that's infants less than 2 months, and the right-hand side is infants less than 6 months. And the lines are all the previous seasons. So the 2022 to 23 season, so the season before was the purple line, for example, and you can see it there. And then the orange bars are the 2023 to 24 season. So that's the season after they'd implemented nirsevimab. And this was in a particular region in Spain where they've got the data from that region and they implemented nirsevimab. So you can see that, the rates of hospitalization for RSV are tiny in comparison to what they've seen in previous years. So just, to look at some more of their data, because you could say, well, maybe they just didn't see RSV last season, maybe actually they had one of those seasons where there wasn't very much. So this is the data from children who were in their second RSV season or aged 1 to 4 years, so wouldn't have been eligible for nirsevimab. So the orange bars again are their hospitalization. You can see that the rates are just as high as they have been in previous years. So they thought there's the same amount of RSV around, it's just that the small babies who had been given nirsevimab weren't hospitalized. So quite exciting real world data. So this is this year's data. So this is, I looked for this today. And this is of the 5th of January. So their current season, again, is the orange bars, and the red line is last year's season. And then the blue lines are their median and range of previous seasons. So again, you can see that last year's season, the red line was much, much lower than the previous ones. And this year, they're seeing similarly very low numbers. I'm just trying to think whether I put it on one of these slides there. I thought I'd put the right numbers of them that had, I can't see it. I wrote down I haven't written it down. I thought I'd written it down. The numbers, the percentage coverage from their data this year is, I think it's something like, I'm really annoyed because I thought I'd written it in my notes. It's something like over 85% for the infants and over 90% for the ones that are vaccinated at birth. There's the ones that have been born before the season and then need to get caught up to be given nirsevimab and the ones that are given it at birth because they're born during the season. But one of them's over 80% and one of them's over 90% in terms of their coverage rate, which is really quite impressive. This is the data from the primary care. So I put this in because, again, I thought this was quite interesting. I didn't see this data last year, but they've obviously decided they're going to look at it this year because, you know, people could say, oh, well, they're not hospitalized, but they're probably still going to their GP. And actually, if you look at this, you can see that their last season is the red line, their primary care, and the season before is the purple line. So the primary care attendances are much lower. And again, it's the same this season, the primary care attendances are lower. So again, you know, it's across the whole system, the whole healthcare system. It's not just the hospitalizations, even though in the study we just looked at hospitalizations. So what about some other places? So the US, so they recommended nirsevimab for infants under 8 months entering or born during the RSV season and high-risk infants older that entering their second season. And there was a publication in one of the neonatal journals that said that nirsevimab reduces the risk of RSV disease requiring medical attention with a number needed to treat of 14 to 24 and hospitalization 33 to 63. That was based on some data from a particular area, I think, in the States. And then looking for the data that's published as part of the CDC reports, they published in March 2024 the early estimate of nirsevimab effectiveness, and that showed that it was 90% effective against RSV-associated hospitalization in infants in their first RSV season. And then this was from another publication that was from September 2024. And they've obviously done some advertising. So this was on the page. I just pulled it off where they're basically saying, you know, almost half of young infants weren't protected last season because they didn't get the antibodies or their mum didn't get the vaccine. So from their data, they had 33% received maternal vaccine, 45% of infants received nirsevimab. So overall, 56% of infants were protected by either one or both, and there were some that did have both. I'm not sure whether that was recommended or whether that was just the way it happened, but that the report here is really interesting because it splits it out into the people with some of the characteristics for people who've accepted it and people who haven't. And probably, as you'd expect, those who are more highly educated, who are of higher socioeconomic status, they're more likely to have accepted either maternal vaccine or nirsevimab, and those who are not, who don't have private healthcare, for example, they're less likely to have. So there is a bit of a class divide, I suppose, in that. So then the UK, what's happened in the UK? So the UK decided to implement maternal vaccine instead of nirsevimab. And apparently, I think it's the UK and Argentina are the only two countries in the world that have chosen maternal vaccine alone. So that in the UK started at the end of September. And our RSV season was, you know, as you can see on this graph, it's the dark blue line is this year's season, October up through November and December. And so most of the babies or mums who would have been eligible, babies have probably been born before the vaccine was starting to be given in the UK. Clinically, I don't think we thought we saw any difference. And looking at these numbers, it doesn't look like our RSV numbers are any different this year from any other year, which obviously is disappointing. We know that their maternal vaccine uptake rates for pertussis in the UK are about 40%. So it wouldn't surprise me if we don't get great coverage from maternal vaccine for RSV. But anyway, that's where we're at in the UK at the moment. I did look, as I was saying to Sanjay before you all joined, that I was looking for some Canadian data, but I wasn't able to find any nice Canadian data with graphs and things like this. So I don't know, maybe at the end someone can show how you guys are finding it. So what else is happening with this study? So it is currently in a second year. So there's an extension made for a second year to look at follow-up for wheezing episodes in the second year of life. And most of that data is being pulled electronically direct from medical records. So there's various criteria that if it's mentioned, the episodes will be pulled and reviewed. because probably, as we all recognise, that babies who have bronchiolitis in the first year of life, particularly the little ones, often do end up having recurrent wheezing episodes and ending up in hospital for those. So again, it's thinking, actually, is there an additional benefit to having had nirsevimab? Might that mean that, if those babies are not coming back in the second year of life with multiple wheezing episodes, actually there's additional benefit to healthcare services and to the child and the family as a result of that. And as I said before, we're trying to kind of use this as a bit of a model for future studies, and saying to, industry, work with us, let us help you to design a study that's actually really going to be deliverable and answer the question that you want to answer. So yeah, just want to say thank you to the whole team, some of the people there on the slide, obviously all of the site staff and investigators, because it was done across a huge number of sites, parents and infants that took part, and then various networks across the UK, France and Germany that helped to support the study, which was sponsored by Sanofi, but jointly funded by Sanofi and AstraZeneca. So thank you very much for listening. I'm very happy to take any questions.